Okay, let's unpack this today. Have you ever wondered what is actually going on in a clinician's head when they walk into an exam room?
Oh, it's a completely different world on their side of the door.
Right, because picture it from your perspective. You are sitting there, you're maybe a little nervous, you're wearing one of those incredibly uncomfortable, crinkly paper gowns.
Usually in a room that's way too drafty.
Exactly. And in walks the doctor or the nurse practitioner or the physician assistant. And they ask you a few questions. They listen to your heart with a cold stethoscope. They type some things into a computer, and then they give you a diagnosis.
Yeah.
And from your perspective on the exam table, it can all feel very routine, almost like a rehearsed script, you know?
hmm
But beneath that surface level interaction, there is this hidden architecture. It is incredibly complex, highly structured, and just deeply fascinating. So, welcome to this custom-tailored deep dive.
Glad to be here for this one.
Our mission today is to give you, the listener, a shortcut to understanding that hidden architecture of the clinical encounter. We are going straight into the art and the science of how healthcare professionals talk to, examine, and document their patients.
And we have a fantastic stack of sources for this.
We really do. We are pulling insights from a foundational medical text, the 13th edition of Bates Guide to Physical Examination and History Taking. We're also looking at a study guide outlining the vital updates for the newer 14th edition of that text.
Right, which brings in a lot of modern context.
And finally, a video lecture transcript focused on the ultimate output of this whole process, which is crafting a SAP note. So the goal here is to understand how medical professionals balance the deeply human, messy elements of healthcare with the intense, rigid clinical precision required to keep you safe.
You know, it is a delicate balance.
Yeah.
And what is so fascinating about these sources right off the bat is how they fundamentally define a clinical skill.
Yeah, how do they define it? Because I just think of, like, taking blood pressure.
Right, we often think of clinical skills as just the physical acts. Stitching a wound, listening for a heart murmur, prescribing a pill. But medical training defines a clinical skill much more broadly. It is any discrete, purposeful act within the overall process of patient care that helps build a therapeutic alliance.
A therapeutic alliance.
Exactly.
Okay.
And there is a profound concept from physician Abraham Verghese that perfectly anchors this entire discussion. He frames the clinical encounter as a profound human ritual.
A ritual. That's a heavy word for a Tuesday morning checkup.
It is, but think about it. One individual comes to a virtual stranger and confesses things they wouldn't tell their closest friends or family members.
Wow, yeah.
And then, incredibly, they disrobe and allow physical touch. Verghese argues that the skills used to interact with and examine a patient have to be worthy of that immense, almost sacred level of trust.
That framing completely changes how you view a standard doctor's appointment. It really raises the stakes. You aren't just a broken car being brought to a mechanic. It's a deeply vulnerable human exchange.
Spot on.
But it also seems like a massive setup for miscommunication, because when you, the patient, and the clinician are in that room together, you're often experiencing two completely different realities, right?
Precisely. And this brings us to a foundational concept in medical training called the disease-illness distinction model.
Disease versus illness. I always thought those were synonyms.
Most people do. But to understand what goes wrong in a clinical room, you really have to understand this split. First, you have the disease.
Okay.
The disease is the clinician's reality. It is the biological pathology. It's how the medical professional organizes your symptoms into a recognizable, treatable biomedical framework.
So the cells, the viruses, the broken bones.
Exactly. But on the other side of the room, you have the illness.
Mm-hmm.
And the illness is the patient's reality. It is your personal construct of how this problem is affecting your life, your relationships, your function, and your daily well-being.
So it's the difference between what is happening in the body biologically versus what is happening in the person's actual life.
Let's look at a really common illustrative example from the text. A patient comes in with a severe sore throat. The clinician immediately activates their disease framework.
Right, they put on their detective hat.
Yeah, their mind is running through a differential diagnosis. They're looking at the back of the throat, checking for swollen lymph nodes, trying to figure out if this is streptococcal pharyngitis or a viral infection or just allergies. They're hunting for biological markers.
But the patient sitting in that paper gown isn't thinking about streptococcal pharyngitis.
Not at all. They're experiencing the illness. That patient might be a freelance worker who is terrified because they don't have paid sick leave, and missing 3 days of work means they can't make rent.
Oh, wow.
Or maybe they're just agonizing over the sheer physical pain of swallowing water, Or perhaps they have this quiet, deep-seated anxiety because a cousin recently had a persistent sore throat that turned out to be throat cancer.
That is such a vivid contrast. The doctor is standing there thinking, is this strep? And the patient is sitting there thinking, am I going to lose my apartment? Or worse, do I have cancer?
Right.
It's no wonder people sometimes leave the doctor's office feeling like they weren't heard at all, even if they got the right prescription.
And that is exactly why modern clinical training emphasizes that a successful encounter has to merge these two approaches. Merging the clinician-centered disease focus with the patient-centered illness focus isn't just about, making the patient feel warm and fuzzy.
It's actual medicine.
It leads to tangibly better, measurable health outcomes. If a clinician only treats the disease and ignores the illness, they might prescribe a $70 antibiotic that the freelance worker simply cannot afford to fill.
And then the infection just gets worse.
Exactly. Or they might completely miss the underlying cancer anxiety, leaving the patient to suffer emotionally long after the strep is cured. To prevent this, the medical field uses a structural framework called the Enhanced Calgary-Cambridge Guides.
The Calgary-Cambridge Guides.
Yes, it breaks the encounter down into 5 highly deliberate steps. Initiating the session, gathering information, the physical examination, explaining and planning, and finally, closing.
Let's hover on that first step for a second, initiating the session, because I was just blown away by how practical and physical the guidance gets before a single medical question is even asked.
Very specific.
It's all about the setup of the room. The guidelines actually instruct clinicians to actively remove physical barriers. So if you are in a hospital bed and the railings are up, the doctor should physically lower them before talking to you.
Oh.
If there is a rolling bedside table between the two of you, they need to push it out of the way. And the clinician is instructed to pull up a chair and sit down so they are exactly at your eye level.
The psychology behind that is critical. If a clinician is standing over you while you are lying in a bed or sitting lower on an exam table, it creates an immediate visceral power imbalance.
It's intimidating.
It triggers a subconscious feeling of being dominated or judged. Sitting at eye level signals partnership. And the guidelines offer some very strict warnings about physical vulnerability to protect that partnership.
Right. There is this incredibly specific yet vital warning in the text. A clinician should never begin a medical interview with a woman who is already positioned for a pelvic exam.
Yeah, that's a major rule.
When I read that, it made complete sense, but it's staggering to think it has to be a formalized rule in a textbook. That is a profoundly vulnerable, exposed physical position.
Absolutely.
The conversation, the history-taking, the building of trust, all of that needs to happen while the patient is fully clothed and sitting upright. Only then should the physical positioning happen.
Because otherwise, the ritual Verghese talks about is completely undermined.
And there are other common sense rules that apparently get broken all the time in rushed hospitals, like not interviewing a patient through a cracked bathroom door, or trying to ask serious medical questions while your back is turned washing your hands.
You cannot ask someone to trust you with their life while you are shouting over the sound of running water with your back turned. It just doesn't work. And building that rapport is highly dependent on who exactly is sitting on the exam table. The training goes into extensive detail on how approaches must shift across different demographics.
It's definitely not a one-size-fits-all endeavor.
Not at all. Consider a 1-month-old newborn. The baby obviously can't articulate their illness experience to the doctor. So the clinician is trained to initially focus entirely on the well-being of the caregivers.
Which makes so much sense. Bringing a newborn in is terrifying for new parents.
It's a massive life disruption. It's accompanied by severe sleep deprivation and high anxiety. So by asking the parents, how are you holding up or are you getting any sleep, the clinician validates their stress.
It drops the temperature in the room.
Yes. It eases the tension, builds trust, and ironically, it makes the parents much more reliable narrators when the clinician actually begins gathering the medical history about the infant.
But as children age, the strategy has to pivot. I found the approach for school-aged kids so charming. The guidance actually suggests clinicians brush up on kid culture.
Kid culture, yeah.
Like if a pediatrician walks in and recognizes the specific cartoon character on a kid's backpack or uses a piece of medical equipment as a playful toy for a few seconds, it instantly dissolves the child's fear. It speaks their language.
It's a great de-escalation tool.
But then we hit the teenage years, and the dynamic seems like a complete minefield. How do clinicians handle adolescents who might be actively hiding things from their parents?
Adolescence requires a very delicate clinical balancing act. The clinician has to respect the family's overall concerns, but they also have an ethical duty to foster and protect the teenager's growing bodily autonomy.
That's a tough tightrope to walk.
It is. The standard protocol here is that the clinician must carve out time to speak with the adolescent patient alone, actively asking the parents to step out of the room for a portion of the visit.
Which I'm sure some parents love.
Oh, it causes friction sometimes. But this creates a confidential safe space where the teen feels secure enough to discuss highly sensitive topics. We're talking sexual health, substance use, or mental health struggles, without fear of parental judgment or reprisal.
Okay, then shifting to the complete other end of the spectrum, you have older adults. The guidelines are surprisingly strict about language here. Clinicians are warned to never use terms of endearment like sweetie, honey, or dear.
Yes, the elder speak warning.
Right, because a nurse or doctor might use those words intending to sound warm and comforting. But to a 75-year-old patient, it often comes across as deeply infantilizing and demeaning. It just strips away their dignity.
Exactly.
And beyond language, the physical environment has to be pre-assessed. Is the room clear of tripping hazards for a patient using a walker? Is the background noise minimized for someone with hearing loss?
Respect is the absolute baseline. And that extends fundamentally into how clinicians are trained to interact with marginalized populations too. For instance, when treating LGBTQ+ patients, the clinical guidance emphasizes establishing an inclusive environment immediately.
How do they do that practically?
Well, clinicians are taught to ask for preferred names and pronouns up front. And the most effective way to do this is for the clinician to offer their own pronouns first during the introduction.
So walking in and saying, "Hi, I'm Dr. Smith. I use she, hers. What name and pronouns do you prefer?"
Yes, because it normalizes the exchange and removes the burden from the patient having to awkwardly correct them later. Now, clinicians are human, and mistakes will happen in a busy clinic.
Sure.
If a clinician accidentally misgenders a patient or uses the wrong pronoun, the protocol is very clear. Apologize simply, correct the mistake, and move on.
The advice to avoid a long, drawn-out apology is so insightful to me. If a doctor spends 3 minutes agonizing and saying, "Oh my gosh, I'm so sorry, I can't believe I did that, please forgive me."
It makes it about the doctor.
Yes. It suddenly makes the patient responsible for comforting the doctor. It centers the clinician's guilt rather than the patient's care. Just a quick, sincerely open, "I apologize," she was experiencing, and keep the focus on the medicine.
That principle of centering the patient's dignity also heavily informs the approach to patients with physical or sensory disabilities. The cornerstone here is people-first language.
Right, the phrasing matters.
Immensely. Medical professionals are trained not to say someone is wheelchair-bound or label them a diabetic. You say they are a person who uses a wheelchair or a person with diabetes.
Because the medical condition does not define the entirety of their human existence.
Exactly. Furthermore, if a patient with a disability brings a companion, a caregiver, or a sign language interpreter into the room, the clinician must maintain eye contact with and speak directly to the patient.
You do not talk over them to their companion.
Never. The default clinical assumption must always be that patients with disabilities are fully competent to manage their own medical care unless there is specific clinical evidence proving otherwise.
Okay, so we've set the stage. The physical barriers are gone. The power dynamic is leveled, and the clinician has recognized the specific humanity of the person sitting in front of them. Now comes the really tricky part, getting the story.
The history taking.
Right. How do you actually get a patient to tell you what's wrong without leading them down a rabbit hole? Because patients aren't medical experts, they might focus on totally irrelevant details.
This is where the skill of gathering information becomes an art form. And medical training uses a very specific visual metaphor for this. They call it the questioning cone.
The questioning cone. Walk me through that. How does it work in practice?
Imagine an inverted cone. You start at the very top, the widest part. This represents broad, open-ended questions. When the clinician first sits down, they should ask something like, "What brings you in today?" Or, "Tell me about the trouble you've been having with your breathing."
Leaving it totally open.
Yes. This is crucial because it allows the patient to construct their own narrative. It brings out the illness experience we talked about earlier. The clinician gets to hear what the patient prioritizes.
But you can't stay open-ended forever, right? I mean, eventually the doctor needs specific data to make a diagnosis.
Exactly. So as the interview progresses, you move down the cone. The questions become more focused. The clinician might ask, "Can you point to exactly where the pain is?" Or, "Does the pain travel anywhere else?"
Narrowing the scope.
You're narrowing it. Finally, at the very tip of the cone, you use closed, rigid yes or no questions. These are used strictly to rule specific biomedical red flags in or out. Have you had a fever over 101? Do you have a family history of heart disease?
What really fascinates me in this section is the strict warning against leading questions. The guidelines explicitly tell clinicians not to say things like, your pain is getting better, right? Or you haven't been coughing up blood, have you?
Leading questions are a massive pitfall in medicine. Patients generally want to please their doctors, or they might feel intimidated by the setting.
The authority figure dynamic.
Exactly. If a doctor says, your pain is improving, right, the patient might just nod and say yes to avoid contradicting the expert, even if they are still in absolute agony.
Wow, and then the doctor writes that down as a fact.
The clinician has just corrupted their own data set. Instead of leading, clinicians are taught to use a technique called echoing.
I love the echoing technique. It feels almost like a conversational magic trick when you read about it.
It really is effective. If a patient is describing their history and says, the pain started in my stomach, but then it got worse and began to spread, the clinician shouldn't interrupt with a completely new question.
They just echo.
They simply repeat the last significant word with an inquisitive tone. They just say, spread, and then they pause. That tiny echo validates the patient and encourages them to elaborate on that specific point without the clinician dictating the direction.
And pausing seems to be something medical professionals really struggle with. There is a statistic in these sources that absolutely floored me. Studies tracking clinical encounters show that, on average, clinicians wait only 18 seconds before interrupting a patient who is explaining their symptoms.
18 seconds.
18 seconds. I haven't even finished clearing my throat and figuring out where to start my story in 18 seconds. Are doctors just naturally impatient, or is there a systemic reason for that reflex?
It is a staggering number, but it's largely a symptom of systemic pressure. Clinicians are often forced to work in environments where appointments are scheduled in strict 15-minute blocks.
The ticking clock.
The clinician feels the immense pressure of that clock, and their disease-focused brain wants to immediately jump to the end of the questioning cone to rule dangerous things out. But interrupting that quickly is a false economy.
How so?
Studies show that when a patient is interrupted, they rarely resume their original narrative. The clinician saves maybe 2 minutes of time up front, but they lose vital context about the patient's illness experience, which often leads to misdiagnosis or noncompliance down the road.
So if a doctor is trained to suppress that urge to interrupt, and they are actively trying to explore the patient's perspective, how do they ensure they cover all the bases? Is there a checklist for the illness side of things?
Yes, there is a very specific mnemonic used in training to ensure the patient's perspective is fully mapped out. It's called FIFE. F-I-F-E.
Okay, let's break FIFE down, because this seems like something every patient listening should know about too. What does the first F stand for?
The first F stands for feelings. The clinician must explicitly ask about the patient's fears or emotional concerns regarding their physical problem. A prompt might be, what worries you the most about these headaches?
Okay, and the I?
I is for ideas. This is uncovering what the patient believes is the root cause of the problem. You ask, what do you think might be causing this stomach pain?
Oh, that's smart. Because they might have been Googling.
Often, the patient has a very specific, terrifying idea, like a tumor, that they simply won't volunteer unless they're directly asked.
That makes total sense. Then the second F is function.
Correct. Function focuses on how the problem is actively disrupting the patient's life. How is this shoulder pain affecting your ability to do your job or play with your kids? It grounds the medical issue in their daily reality.
And finally, the E.
E is for expectations. What does the patient actually want out of this specific visit? How specifically can I help you today?
Because they don't always want a pill.
Sometimes a patient doesn't want a prescription at all. They just want a doctor to reassure them that their cause isn't pneumonia. If the doctor doesn't ask, they might prescribe an inhaler the patient doesn't want and will literally never use.
But here's the thing. If a doctor uses the FIFE framework, they are basically inviting the patient to open an emotional floodgate. If you ask someone about their deepest fears and how a disease is ruining their function, they might start crying or get angry.
It happens all the time.
And doctors are highly trained scientists. They aren't therapists. How are they supposed to handle that emotional weight without the 15-minute appointment completely derailing?
That is a very real challenge, especially considering the text knows that 30 to 40% of primary care patients have underlying anxiety or depression. When a patient drops an emotional cue, whether it's tears, a heavy sigh, or a flash of anger, The clinician cannot simply stare blankly and then ask about their blood pressure.
That would just shatter the therapeutic alliance.
Completely. So, medical training provides another structured framework to handle emotions efficiently but empathetically. It's the NRSE mnemonic.
NURSE. I really want to see how this works in practice. Let's walk through a scenario. Let's say I'm a patient and I just found out I have a chronic condition like diabetes. And I say to the doctor, I just can't do this. I'm going to end up losing my foot like my dad did. It's hopeless. How does the doctor use the NRSE framework to respond to that?
Let's break it down letter by letter using your scenario. The clinician starts with N, which is name the emotion. They don't guess. They say what they observe. The clinician might say, "It sounds like you are feeling incredibly overwhelmed and terrified right now."
Okay, that immediately makes me feel seen. What's the U?
U is for understand or legitimize the emotion. The clinician validates your reaction so you don't feel crazy. They would say, "It is completely understandable that you feel that way, especially given what happened to your father."
Wow, acknowledging the dad's history is powerful there. Then comes R.
R is for signing. Respecting the patient's resilience. You find a positive core to focus on. The clinician could say, "Despite how hopeless it feels, I want to acknowledge that you took a huge step just by coming in to get tested today." It shows a lot of strength.
I can literally feel the tension dropping in this hypothetical scenario. What is the S?
S is for support. This is where the clinician commits to the partnership. "I want you to know that you aren't doing this alone. Our whole care team is going to support you in managing this."
And finally, the E.
E is for explore further. You invite them to elaborate if they need to. Is there anything else about the diagnosis that is frightening you?
That's a great off-ramp.
By moving through name, understand, respect, support, and explore, the clinician validates the massive emotional weight without having to act as a long-term psychotherapist. It maintains trust and allows the medical interview to continue safely.
That is just a brilliant piece of conversational engineering. But I imagine even with all these frameworks, doctors run into patients who just completely defy the structure. Human behavior is messy. How does a clinician handle a patient who refuses to talk? The silent patient.
The silent patient is a classic clinical challenge, and it often induces panic in novice clinicians. When there is a long stretch of silence, the natural human instinct is to fill the void with chatter or a barrage of new questions.
Just to make it less awkward.
Exactly. But the clinical guidance is to resist that urge. Silence isn't inherently a bad thing. Often it is deeply therapeutic.
What are they doing during the silence?
The patient might be trying to recall a difficult timeline, or they might be silently debating whether they trust the clinician enough to reveal something highly stigmatized like domestic abuse or substance use. The clinician is trained to sit attentively, maintain an open posture, and let the silence breathe.
So don't rush the quiet, but what about the exact opposite? What about the talkative patient? The person who sits down and immediately starts giving you an unedited, rambling history of every ache and pain they've had since 1998, their neighbor's dog, and what they had for breakfast.
We all know that person.
How do you stop them without being horribly rude?
The guidelines are surprisingly generous here. The advice is to give the highly talkative patient about 5 to 10 minutes of completely free rein.
10 minutes in a 15-minute appointment, that's a massive chunk of time.
It is, but it's often necessary. Sometimes a patient just desperately needs to be heard, or their rambling is actually a smokescreen for a deeper, severe anxiety they are afraid to articulate. But once that window closes, the clinician must take control.
How do they do that nicely?
They do this by politely but firmly interrupting, summarizing what they've heard to prove they were listening, and forcing a pivot. The clinician might say, "Mr. Davis, I'm hearing that you have concerns about your back pain, your digestion, and your sleep schedule. Because we have limited time today, I want to make sure we address the most dangerous issue. Let's focus entirely on the back pain today, and we will schedule a follow-up for the digestion."
It's polite boundary setting. I like that. But there's a third type of challenging patient mentioned that seems a bit scarier, the patient with a confusing narrative, where the story just fundamentally doesn't add up.
Yes, and this is where a clinician's diagnostic alarms really need to ring. A confusing narrative can mean a few things. Sometimes it's what medical professionals call a positive review of systems.
What does that mean?
This is a patient who will say yes to literally any symptom you ask about. Do your teeth hurt? Yes. Does your left toe tingle? Yes. Do you have chest pain? Yes. In these cases, the confusion is often rooted in severe somatic anxiety or a psychosocial issue, and the clinician must pivot to exploring their emotional state.
But it could also be a physical brain issue, right?
Exactly. If the timeline of events makes zero logical sense, or the patient is clearly confabulating, meaning their brain is inventing false memories to fill in gaps, it could signal an acute physical emergency, like delirium caused by an infection or the onset of dementia.
So they have to stop the normal interview.
When a clinician spots this, they must immediately abandon the standard interview and perform a mental status exam to assess the patient's level of consciousness, orientation to reality, and cognitive function.
Okay, so we've been looking very closely at the interpersonal dynamics inside that small exam room. But let's zoom out for a minute. A patient's health isn't just determined by what happens in the clinic. The sources make a profoundly bold statement here. They argue that your zip code is often a much better predictor of your health and lifespan than your genetic code.
It's a sobering reality.
This brings us to the concept of social determinants of health, or SDOH.
This is a major focus in modern clinical training. The World Health Organization defines social determinants of health as the broader conditions in which people are born, grow, work, live, and age. Medical science now explicitly recognizes that these non-medical factors play a dominant role in shaping health outcomes.
What are the specific categories they train doctors to look for when they assess this?
The frameworks usually break SDOH down into several key domains. You have economic stability. Can the patient actually afford food and housing?
Yeah.
You have education. What is their health literacy level? There's the social and community context. Do they have a support system, or are they experiencing systemic discrimination?
Like structural factors.
Right. There's healthcare access. Do they have insurance? And is there a clinic nearby? And finally, the neighborhood and built environment. Is their air polluted? Is their neighborhood safe to walk in?
It really recontextualizes medicine, because a doctor can be a diagnostic genius and prescribe the absolute perfect cutting-edge medication. But if that patient lives in a food desert, works 3 part-time jobs, and is facing eviction, that medication isn't going to solve their health crisis.
Exactly. Modern training demands that clinicians integrate these social realities into the actual medical plan. But recognizing the external forces acting upon a patient is only half the battle. The training also forces clinicians to look inward at their own internal forces, specifically their biases.
Right.
Now, as we discuss the clinical definitions of bias, racism, and discrimination provided in the source material, it's important to note that we're impartially reporting the exact frameworks taught to medical trainees. We're looking at this through a purely clinical and educational lens to understand how future healthcare providers are being trained to navigate these realities.
Right, we are just looking at the textbook frameworks, and the foundational clinical distinction made here is between explicit bias and implicit bias. Explicit bias is what most people think of when they hear the word. It is conscious, intentional discrimination.
Like refusing care based on demographics.
Exactly. A patient looking at a doctor and refusing to be treated by them because of their race. Or a clinician who consciously believes a derogatory stereotype about a specific demographic and willfully alters their care because of it. It's overt. But the sources spend a lot of time on implicit bias, which seems much more insidious because it happens beneath our awareness.
It is entirely unconscious, which is what makes it so dangerous in a medical setting. The examples given in clinical training highlight how subtle it can be. It's a doctor who unconsciously, audibly sighs in frustration the moment they see a patient with a substance use disorder on their schedule.
A micro-reaction.
Or it's a patient who repeatedly assumes the female physician walking into the room is the nurse, despite her wearing a badge that clearly says MD.
What I found really interesting is how medical training actually explains why implicit bias exists from a neurological standpoint. The sources frame it not as a moral failing initially, but rather as an evolutionary glitch.
That's a great way to put it based on the text. The human brain is bombarded with millions of pieces of sensory information every second. To prevent us from being paralyzed by information overload, our brains evolved a cognitive efficiency system.
A shortcut system.
We unconsciously sort information, recognize patterns, and make split-second categorizations to survive. However, in modern society, we are constantly exposed to pervasive societal stereotypes. Our brain absorbs those stereotypes and wires them into our unconscious pattern recognition system.
So it's happening without permission.
So, in a fast-paced, high-stress clinic, a clinician's brain might automatically implicitly link a specific demographic with negative traits like noncompliant or drug-seeking.
And even if the doctor doesn't consciously believe it, that unconscious wiring bleeds into their behavior?
Precisely. It manifests in subtle, nonverbal cues. A clinician with implicit bias might make less eye contact, physically stand further away from the patient, use a more dismissive tone, or rush the interview. The patient instinctively feels that distrust. And when you multiply those thousands of micro-interactions across an entire healthcare system, implicit bias coalesces into massive institutional bias, leading to statistically worse care and higher mortality rates for marginalized groups.
So how on earth does a doctor fix a biological glitch they don't even know is happening? The training doesn't just say, stop being biased. It introduces a concept called cultural humility, which is distinct from cultural competence.
Very distinct.
It's not about memorizing a textbook checklist of facts about different cultures like group X eats this or group Y believes that. It's an internal practice.
Cultural humility is framed as a lifelong commitment to self-evaluation. It requires the clinician to relinquish the role of the all-knowing expert and instead let the patient be the expert on their own cultural experience. To operationalize this, trainees are taught a coaching tool called the 5 R's.
Let's run through those. What are the 5 R's?
The first is reflection. The clinician must constantly ask themselves, did I just make an assumption about this patient based on their appearance? The second is respect. Are they treating the patient with dignity?
That's two.
A third is regard. Does the clinician hold the patient in high esteem, regardless of their social standing? The fourth is relevance. Is the clinician asking questions that actually matter to the patient's cultural context? And the fifth is resiliency, acknowledging the patient's inherent strength in navigating the healthcare system.
It's a heavy cognitive load for a provider to always be running that checklist. But the training also addresses a very modern, highly volatile scenario. What happens when the bias and discrimination flow in the opposite direction?
Which absolutely happens.
What happens when it is the patient who is being explicitly racist, sexist, or discriminatory toward the medical trainee or the doctor?
This is a distressing reality, and modern clinical frameworks provide a very specific phased protocol to protect trainees while upholding the oath of care. Step 1 is clinical triage. The medical professional must instantly assess the illness acuity.
Are they dying, basically?
Right. Is this patient actively having a heart attack or bleeding out? If it's a life-threatening emergency, the medical duty to treat supersedes the abuse and care must continue. However, if the patient is stable and non-emergent, the trainee is explicitly instructed to step away and seek a supervisor's help.
And the supervisor isn't supposed to just tell the trainee to tough it out like maybe they did decades ago?
No, the era of expecting trainees to silently endure abuse is ending. The framework empowers the supervising physician to enter the room and directly name the discriminatory behavior. The supervisor is instructed to use clear, unambiguous language.
Like what?
They might say, Mr. Smith, are you refusing to let this medical student examine you because of their race? The goal is to address the behavior explicitly, reinforcing that the institution will not tolerate a hostile environment while still attempting to negotiate a path forward for the patient's care.
It's incredible how much of medicine involves navigating these intense human conflicts, and that transitions us perfectly into the realm of medical ethics, hard conversations, and behavior change. Let's start with a foundational distinction the sources make clear before getting into the heavy ethical dilemmas. The difference between religion and spirituality, because they are not interchangeable terms in medicine.
They're distinct concepts, though they often overlap. Religion is defined as a specific system of beliefs, texts, and rituals shared by a community like Catholicism, Islam, or Judaism. Spirituality, however, is much broader.
It's more personal.
It is defined as a human being's personal search for meaning, purpose, and connection to something larger than themselves.
And the text points out a massive demographic shift in the United States regarding this. The rapid rise of the spiritual but not religious patient. A doctor can't just ask, what church do you go to anymore?
Right, because the answer might be none.
A patient might find their profound sense of spiritual purpose in volunteering or being out in nature, or even, as the training surprisingly points out, in a highly intense fitness community like CrossFit.
The reason clinicians are taught to explore this, using tools like the FIFE spiritual assessment tool, is because spirituality acts as a profound social determinant of health. A strong spiritual foundation can increase longevity, improve mental health, and aid in recovery.
And the reverse is true, too.
Conversely, a patient experiencing a spiritual crisis, feeling abandoned by their God or losing their life's purpose, can experience severe physical decline. But exploring deeply held beliefs and personal values inevitably leads to friction. And that friction is governed by the 4 pillars of medical ethics.
Let's define those 4 pillars so we have the vocabulary for the case study we're about to dive into.
The first pillar is beneficence. This is the affirmative duty to act in the patient's best interest, to do good. The second is non-maleficence. This is the ancient Hippocratic principle, first, do no harm.
Doing good versus not doing bad?
Right. The third is respect for autonomy. This is the fundamental commitment to respect the informed choices a patient makes about their own body and life. And the fourth is justice, which demands that medical resources and treatments are distributed fairly among all patients.
On paper, those sound great, but in the real world, they constantly crash into each other. The training provides a fascinating, highly complex case study about a patient named RG that perfectly illustrates this crash. Let's unpack RG's story.
RG is a 30-year-old man who comes into the clinic recovering from shoulder surgery. A medical student is taking his history. RG is very chatty and enthusiastic, and he openly tells the student about his extensive past use of hallucinogenic drugs during his high school and college years.
He's just volunteering all this info.
He lists them off. LSD, psilocybin, ketamine, you name it. He hasn't used them in years, but it's a significant part of his history.
But then, at the very end of the visit, the mood shifts. RG looks at the medical student and explicitly says, "Do not write any of that drug history down in my medical chart."
Exactly. And his reasoning is highly specific. RG explains that he's currently applying for a job with the local police department. He is incredibly paranoid that the police department will somehow hack into his electronic medical records, see his past LSD use, and disqualify him from the job.
So, as a medical student, what do you do? If I'm RG, I'm thinking, it's my life, it's my data, and my past drug use has nothing to do with my shoulder surgery. Respect my autonomy and leave it out. But the doctor has to worry about the medical record.
This is a classic, high-stakes ethical dilemma. The principle of autonomy, RG's right to control his data, is colliding head-on with beneficence, the doctor's duty to provide safe, accurate care. To resolve these collisions, clinicians are taught to use a 6-step heuristic, which is a practical framework for ethical decision-making.
Walk me through the 6 steps as they apply to RG.
Step 1 is to clearly state the ethical question. In this case, should the clinician record the remote history of drug use, despite the patient's explicit request to omit it? Step 2 is to collect all the relevant information. This includes the medical facts, the drugs used, patient preferences like RG's fear of the police, and the context, which is the electronic health record system.
Okay, gathering the board pieces.
Step 3 is identifying the specific ethical principles at play. As we noted, it's autonomy versus beneficence, but also confidentiality.
Okay, so you've mapped the battlefield. What are steps 4 and 5?
Steps 4 and 5 involve evaluating the options and making a decision based on ethical weighting. The clinical guidance comes down firmly on this. The clinician must document the drug history.
Oh, RG's gonna be furious. Why does the doctor override him?
The ethical reasoning is that respect for autonomy gives a patient the right to refuse a treatment, but it does not give a patient the license to dictate the clinical accuracy of a legal medical document. A medical record is not just a personal diary. It is a communication tool for the entire healthcare team.
It's for future reference.
What if RG is brought into the ER unconscious next year, and they need to administer a medication that has a fatal interaction with past hallucinogen use? If the record is falsified by omission, the doctors are flying blind. Therefore, beneficence acting for the ultimate safety of the patient via an accurate medical record outweighs the patient's desire to censor the data.
That makes clinical sense, but step 6 of the heuristic is creating an action plan. That you can't just secretly write it down while RG isn't looking. That would destroy the Verghese ritual of trust.
Exactly. Step 6 mandates that the clinician must have the hard conversation with RG. They had to sit down and clearly explain why the information must be recorded for his future safety. But crucial to this step is addressing RG's actual fear.
The police hacking fear.
The clinician must explain the robust, legally mandated security protocols, like HIPAA in the U.S., that protect electronic health records. They must reassure RG that it would be a massive federal crime for a police department to hack into his medical chart. You validate his fear, explain the reality, and maintain the integrity of the medicine.
Having that kind of intense conversation requires the patient to be in their right mind. Which brings up critical legal and clinical distinction the sources highlight. Decisional capacity versus legal competence. People use those words interchangeably, but they are vastly different in medicine.
It is a vital distinction that dictates who is allowed to make choices. Competence is strictly a judicial determination. Only a judge in a court of law can declare someone legally incompetent and assign them a guardian. A doctor cannot declare you incompetent.
But a doctor can determine if you have decisional capacity.
Yes. Capacity is a clinical designation determined by the healthcare provider right there in the exam room. To possess decisional capacity, a patient must demonstrate four things. First, they must be able to communicate a clear choice. Second, they must understand the relevant medical information being provided. Third, they must appreciate the consequences of their decision. And fourth, they must be able to use logic and reason to arrive at their choice.
And the fascinating thing about capacity is that it isn't permanent. It's situational and temporal.
Right, it fluctuates.
A patient might be brought in with a massive fever and delirium. Today, they lack capacity because they are hallucinating. But tomorrow, after the antibiotics work and the fever breaks, they regain their capacity. Or a patient with mild dementia might have the capacity to decide what they want to eat for dinner, but they lack the complex reasoning capacity to consent to open-heart surgery.
And assessing capacity becomes incredibly urgent when a clinician has to deliver devastating medical news, which is one of the heaviest burdens in the profession. Medical training provides a very specific protocol to guide clinicians through the agonizing process of giving bad news, designed to minimize trauma for both the patient and the provider. It's called the SPIKES protocol.
Let's do a role play of spikes, because I think everyone dreads being on either side of this conversation. Let's say you are the doctor, and you have to tell me that my recent biopsy came back positive for cancer. What does the S stand for?
S stands for setting up the interview. Before I even speak to you, I ensure we are in a private room, my pager is turned off, and I physically sit down so I am not looming over you. Then we move to P, which is assessing the patient's perception. I need to know what you already suspect. I might ask, before we discuss the biopsy results, can you tell me what your understanding is of why we did the test?
That prevents the doctor from just dropping a bomb out of nowhere. I might reply, well, you said there was a lump, but I figured it was just a cyst. What's the I?
I is for obtaining the patient's invitation. I ask how much detail you want. I have the results of your biopsy. Are you someone who wants to know all the specific medical details right now? Or would you prefer a general overview of the big picture? Some patients want every data point, others just want the bottom line.
Okay, so I say, give it to me straight. I want to know. Now comes the K.
K is for giving knowledge. This is the moment the news is delivered, and the rule is to fire a warning shot first, followed by clear, non-jargon language. I would say, I am so sorry to tell you this, but the biopsy results show that the lump is cancerous.
It's awful to hear, but it's clear. There's no confusing medical terminology. Then what?
Then comes E, which is addressing emotions with empathy. This loops back to the NRC mnemonic we discussed earlier. I sit in silence, let you process the shock, offer tissues, and validate whatever reaction you have. Finally, S is for strategy and summary. Before you leave the room in a daze, I ensure we have a concrete next step. I know this is overwhelming. We don't have to decide on a treatment plan today, but I want you to come back on Thursday with a family member and we will talk to the oncologist together. Does that sound okay?
It's a structure that holds the doctor upright when everything is falling apart. And delivering bad news naturally transitions into conversations about the end of life. The clinical guidance points out a massive hurdle in these discussions, and it's actually television.
Yes. Television medical dramas have severely warped the public's perception of end-of-life care, specifically regarding cardiopulmonary resuscitation, or CPR. On TV, an elderly patient's heart stops. The doctors do heroic CPR for 2 minutes, and the patient wakes up perfectly fine and asks for a sandwich.
But the clinical reality is brutal.
It is incredibly traumatic. For frail, elderly, or terminally ill patients, CPR involves aggressively breaking ribs, severe organ damage, and extremely low rates of survival to discharge. Clinicians are trained to clearly dispel the TV myth.
How do they ensure the patient's real wishes are followed?
To ensure a patient's true wishes are honored in a crisis, the medical field uses formal, actionable documents, like the Publius or Multiforms physician or medical orders for life-sustaining treatment. Unlike a generic living will, these are brightly colored, standardized medical orders that dictate exactly what emergency responders are allowed to do regarding CPR, intubation, and feeding tubes, ensuring the patient's autonomy is respected even when they cannot speak.
But what about when a patient isn't dying, but they are actively engaging in behaviors that are destroying their health? How does a doctor convince someone to change their habits? If a patient is smoking a pack a day or drinking heavily, a doctor can't just wag their finger and lecture them. People hate being told what to do.
Lecturing is clinically proven to fail. It just causes the patient to become defensive and dig their heels in. Instead, modern training uses a psychological technique called motivational interviewing. The core philosophy of motivational interviewing is to roll with resistance rather than fight it.
It sounds like conversational judo. Let's look at the example they provide. It's a really intense scenario about a patient who was brought into the ER intoxicated. She tells the psychiatrist that she is an alcoholic, she loves drinking, and she absolutely will not stop no matter what. A bad doctor would just hand her a pamphlet on liver cirrhosis and tell her she's making a mistake. How does the judo work?
The psychiatrist in the example takes a completely counterintuitive approach. First, they ask permission to discuss it. When the patient refuses to stop drinking, even while admitting her liver is failing, the clinician doesn't argue. Instead, the clinician simply reflects the logical extreme of the patient's statement back to her. The clinician says, calmly, "It sounds like you don't care much whether you live or die."
Whoa, that is a heavy thing to say.
But look at the psychological effect. By stating the grim reality without judgment, it forces the patient to confront the discrepancy in her own logic. The patient immediately recoils and says, "No way, I love life. I don't want to die."
The doctor got the patient to argue for her own survival.
Exactly. The clinician successfully evoked what is called change talk from the patient herself. By highlighting the discrepancy between her stated desire to live and her destructive behavior, the clinician plants the psychological seed for behavior change without ever being confrontational. It is a highly advanced clinical skill.
Okay, we've covered the interpersonal, the ethical, and the psychological. Now let's shift gears to Section 5, Modern Realities. The study guide for the 14th edition updates these foundational skills to reflect what a clinic actually looks like today. For decades, a doctor's appointment was a dyad, just the clinician and the patient. But today, it is a triadic relationship. It is the clinician, the patient, and the glowing screen of the electronic health record, the EHR.
The EHR is the defining double-edged sword of modern medicine. On one hand, it has vastly improved patient safety. It eliminates unreadable handwriting, flags dangerous drug interactions instantly, and allows data to be shared across hospital systems. But physically and cognitively, it creates a massive barrier in the exam room. Clinicians often find themselves staring at a screen, clicking boxes, instead of looking at the patient.
And the patient feels like they're competing with a laptop for attention. So how do the guidelines suggest doctors manage this third wheel in the room?
There are specific strategies taught to maintain patient-centeredness while interacting with the machine. First is the physical setup. Clinicians are advised to construct a triangle formation. The patient, the clinician, and the monitor should form a triangle so the clinician can easily pivot their gaze back and forth without turning their back on the patient. Second, they're encouraged to visually share the screen. Turn the monitor so the patient can see their own lab results or x-rays. It demystifies the process.
I also read the advice about reading out loud while typing. If the doctor is documenting my symptoms, they should say them out loud. Patient notes, sharp pain in the lower right quadrant. That way, I'm not just sitting there listening to sterile keyboard clicking, wondering what secret notes they are taking. I can actually verify the accuracy. And they also suggest using natural gaps in the encounter, like when a patient is putting their shoes back on, to do the heavy data entry.
Exactly. And technology isn't just about the EHR. It's about how modern healthcare teams communicate with each other. In a hospital, a patient might be seen by 3 nurses, 2 specialists, and a physical therapist in one day. Handoffs are where deadly errors occur. To prevent this, medical professionals use a strict communication framework called SBAR.
SBAR. How does that streamline communication?
SBR stands for Situation, Background, Assessment, and Recommendation. It strips away all the rambling narrative and gets straight to the clinical point. For example, a nurse calling a doctor at 2 a.m. wouldn't start with a long story. They would say, Situation. Mr. Jones in room 4 is experiencing severe shortness of breath. Background. He is 2 days post-op for a knee replacement. Assessment. His oxygen levels are dropping, and I suspect a pulmonary embolism. Recommendation. I need you at the bedside immediately to order a CT scan.
It's almost military in its precision. It removes all ambiguity, and there is a similarly rigid protocol for communicating across language barriers, which is incredibly important as demographics shift. The mnemonic is interpret. But the most vital rule I took away from this section is the absolute ban on using family members to translate.
This is a critical safety issue. It's incredibly tempting and often seems faster to just ask a patient's bilingual teenage daughter to translate what the doctor is saying. But the guidelines explicitly forbid this.
Why? If the kid speaks both languages, what's the harm?
2 major reasons. First, it completely violates the patient's medical confidentiality. Second, it leads to dangerous miscommunications. Family members, especially children, will often intentionally omit terrifying diagnoses to protect their parents, or they lack the complex medical vocabulary to translate correctly. The clinician must use a qualified professional medical interpreter. And when using an interpreter, the golden rule is to maintain the therapeutic alliance with the patient.
Right. You don't look at the interpreter and say, ask him how long his chest has been hurting. You look directly into the patient's eyes and speak to them. How long has your chest been hurting? The interpreter is just a conduit.
Precisely. Now, alongside these modern communication updates, the 14th edition takes a deep dive into the actual cognitive science of how doctors make diagnoses. They introduce a concept called dual process theory in clinical reasoning.
Let's break down dual process theory. It sounds complex, but it maps perfectly onto how all of us think every day. It splits human thought into two systems, System 1 and System 2.
Let's define them. System 1 thinking is intuitive, incredibly fast, and based entirely on pattern recognition. It operates almost automatically. In a medical context, it's the kind of thinking an experienced ER nurse uses. They walk into a trauma bay, take one glance at a patient's ashen skin color, note the specific rhythm of their breathing, and instantly, without thinking about it, know the patient is in shock. It's unconscious expertise.
If I were to relate that to everyday life, System 1 is how you drive your car to work. You don't actively think, press the brake with 3 pounds of pressure, turn the wheel 20 degrees. You just do it automatically while listening to a podcast. But System 2 is different.
System 2 is analytic, slow, deliberate, and highly evidence-based. It requires intense cognitive effort. In medicine, this is a doctor sitting down with a complex, mysterious set of symptoms, writing out a long differential diagnosis list, and methodically ordering lab tests to rule out diseases one by one.
And the everyday equivalent, System 2, is parallel parking in a tight space on a busy street. You turn the radio down, you grip the wheel, and you actively calculate every angle.
That is a perfect analogy. And clinical training warns that while System 1 is necessary for efficiency, relying too heavily on it in modern medicine leads to cognitive biases. Diagnosing a patient isn't always as simple as driving a familiar route. The guidelines explicitly warn against specific traps, like anchoring bias.
How does anchoring bias play out in a hospital?
Imagine a patient is transferred from an urgent care clinic to the ER with a note that says, "Suspected anxiety attack." The ER doctor reads that note. Their System 1 brain anchors on the diagnosis of anxiety. Because of that anchor, they miss the subtle signs that the patient is actually having a heart attack. Another trap is confirmation bias, where a clinician gets an initial hunch and then unconsciously only looks for lab results that prove their hunch, completely ignoring glaring data that contradicts it.
So the goal is to use System 2 thinking to double-check the rapid-fire assumptions of System 1. And that brings us perfectly to our final, ultimate destination, Section 6. Documenting the encounter. Everything we've talked about, the empathy, the disease versus illness, the ethics, the systemic biases, the System 2 cognitive processing, all of it must be distilled into a single permanent record, the SOAP note.
The SOAP note is the architectural blueprint of modern medical care. It serves as legal protection. It is the primary communication tool for future clinicians, and it forces the doctor to demonstrate their clinical reasoning. The 14th edition updates emphasize that the center of the modern medical record is the problem list, a running tally of everything a patient is battling, but the daily documentation follows the rigid SOAP structure.
Let's look at the exact definitions of the letters, and then I really want to walk through the video case study of Mr. Fred Kloa to see how a messy human encounter gets translated into this rigid structure. What is the S?
S stands for subjective. This section is entirely narrative. It is the story the patient tells you. It includes the chief complaint, why they are here, and the history of present illness. It captures the patient's illness reality. Crucially, there is no objective medical data here, just what the patient reports.
Then comes the O.
O is objective. This is the realm of verifiable scientific fact. Vital signs, physical examination findings, what the doctor sees, hears, and feels, and laboratory results. There are no patient opinions or clinician guesses allowed in this section.
So S is what the patient says, O is what the machines and the exam show. Then what?
Then the clinician moves to A, the assessment. This is where System 2 analytical thinking shines. The clinician synthesizes the subjective story and the objective data to state what they believe is happening. It contains the primary diagnosis and often a differential diagnosis of other possibilities. Finally, P is the plan. This details exactly what the clinician is going to do about it. Prescriptions, further testing, patient education, and when the patient needs to return.
Okay, let's see. This machine in action with Fred Kloa. Fred is a 62-year-old male who comes into the clinic complaining of a terrible sore throat. The doctor sits down, establishes the Verghese ritual of trust, and starts gathering the subjective information. How does that read in the note?
The clinician types, subjective. 62-year-old male presents with a sore throat. Reports pain as a 6 out of 10 and worsens at night. States the pain began 2 days ago. Patient measured his temperature at home and reports a maximum fever of 102 degrees. He denies having a cough or a runny nose. The clinician also notes under the subjective history that Fred is allergic to sulfa drugs and routinely takes 10 milligrams of lisinopril for high blood pressure. All of this is purely Fred's narrative.
Then the doctor transitions to the physical exam and gathers the objective data.
The objective section would look like this. Vital signs. Heart rate is 77. Blood pressure is elevated at 158/92. Physical exam. Posterior oral pharynx is erythematous, which means red. Tonsils are hypertrophied, swollen, with white exudate present. The video lecture humorously describes this exudate to the students as a bunch of white junk on big tonsils. Finally, palpation of the neck reveals tender anterior cervical lymph nodes. This is pure, unarguable data.
Now, the doctor has to put the puzzle pieces together in the assessment section, and the sources point out that diagnosing strep throat isn't just a random guess. They use a specific metric called the center criteria, right?
Yes, the clinician uses System 2 analytical thinking. They look at the center criteria, which assigns points for specific strep symptoms. Fred gets points for having a history of fever, having swollen and tender lymph nodes, having white exudate on his tonsils, and crucially, for the absence of a cough. Because he meets 4 out of the 5 criteria, the clinical probability of strep is very high. So the assessment reads 1, Streptococcus pharyngitis. But a good clinician doesn't stop there.
Right, because his objective blood pressure was 158/92, which is high.
Exactly. Even though Fred didn't complain about his blood pressure, the objective data caught it. And since his subjective history notes he is already on 10 milligrams of lisinopril, the medication clearly isn't working well enough. So the clinician adds a second assessment. 2, uncontrolled essential hypertension.
Which leads to the final step, the plan. How do they fix Fred?
The plan addresses both assessments. For the strep throat, the clinician prescribes penicillin VK for 5 days, noting his sulfa allergy from the subjective section, and recommends supportive care like saltwater gargles. But to address the underlying chronic issue, the clinician adjusts his blood pressure medication, increasing the lisinopril from 10 milligrams to 20 milligrams. Finally, the plan dictates a follow-up appointment in 3 days to check his throat and recheck his blood pressure.
It is so satisfying to see how every single framework we discussed today funnels into that one concise document. The doctor listened to his subjective illness, gathered the objective disease data, used System 1 pattern recognition to spot the strep, used System 2 analysis to calculate the center criteria and catch the hidden hypertension, and formulated a comprehensive plan. So what does all of this mean for you, our listener? We have gone on an incredible journey today. We've explored the hidden psychology of the exam room, from why a doctor lowers a bed rail to level the power dynamic, to how they are trained to politely interrupt a 10-minute monologue. We've uncovered the deep significance of cultural humility and the neurological roots of implicit bias. We've wrestled with heavy ethical collisions between a patient's autonomy and a doctor's duty to do no harm. And we've learned how conversational judo can spark behavior change. And we've seen how all that messy, beautiful, complex humanity is ultimately distilled into the rigid, clinical architecture of a SOAP note.
The ultimate takeaway here is empowerment. Whether you are a patient shivering in a paper gown or a medical student donning a white coat for the first time, this architecture dictates your healthcare experience. It isn't arbitrary bureaucracy. It is a highly evolved system designed to protect the ritual of trust. By understanding these frameworks, by knowing you can use the FIFE mnemonic to clearly articulate your fears and expectations, and by understanding the rigid logic of the SOAP note, you are no longer a passive recipient of medical care. You understand the language of the encounter. You become an active, empowered partner in your own health.
I couldn't agree more. But as we wrap up, I want to leave you with one final provocative thought to mull over. We talked about how the electronic health record turned the doctor-patient duo into a triadic relationship. But as we sprint further into the reality of the 21st century, how is artificial intelligence going to disrupt this sacred triad? Right now, AI models are being deployed that can silently listen to a medical conversation and perfectly auto-generate a flawless OAP note in seconds. And AI can calculate System 2 analytics, differential diagnoses, and center criteria instantly, completely free of human anchoring or confirmation bias. If a machine can perform the clinical data gathering and the assessment faster and more accurately than a human, what happens to the clinical encounter? Does this technology liberate the human doctor, allowing them to ignore the computer screen entirely and focus 100% of their energy on empathy, eye contact, and the FIFE mnemonic? Or does inserting an algorithmic black box between the patient and the doctor fundamentally alter that profoundly human ritual that Abraham Verghese described? Will we ever be able to trust a machine with our most intimate physical and emotional vulnerabilities the way we trust a fellow flawed human being?
Yeah.
Something to ponder until our next deep dive.